name is Eddie Williams. I'm an assistant professor at Boston College School of Social Work and director of the Black Mental Wellness Research Lab. Um, I have to preface that with saying like it's a lab that's in development phase. So if you Google us, we may not show up yet, but I'm working on it. I promise you I'm working on it. But my research primarily focuses on the mental health experiences of Black autistic youth and their mental health help-seeking behaviors, and thinking about really how we can address those mental health needs and use unique, innovative kind of approaches to improve mental health outcomes for Black autistic youth. Before I dig really deep into this work, I'm going to start off with I talk really fast. I'm going to do my best to slow down. I can't see anybody, so I can't tell if I'm talking really fast and getting confusing. So I'm going to do my best to remind myself to slow down. And I get really excited about my work. And so just to kind of start that off. Also, I like to always start off with kind of how I approach my work. I'm a social scientist for the most part. My PhD is in social work and sociology. So I tend to approach my work primarily, especially in autism, with from a social model. Though I kind of fall somewhere in between the medical model, also being a clinician and things of that nature. But I tend to use identity first language, though I know there's some debate in the field and in the community about that. I treat autism as a social identity, meaning that I understand and identify shared social experiences of autistic individuals, understand that there are social consequences associated with being labeled autistic in our society. And many of the outcomes for autistic individuals are impacted by social determinants outside, beyond just the medical diagnosis, right? Also, the way I use the term Black throughout my talk and just in my own kind of personal conversations is an all-encompassing racial category, right? So that's African-American, Afro-Latino, Afro-Caribbean, biracial, multiracial, anybody who identifies African ancestry and Blackness as a core racial identity for themselves. And then finally, I'll kind of differentiate between mental health diagnosis and a mental health symptomology. And so to be depressed or have depression as a diagnosis versus to experience depressive symptoms. And that's important as we talk about Black people, because research has shown us and data has shown us that though Black people are underdiagnosed with depression, they tend to overreport depressive symptomology. And that's important. So it's important to kind of differentiate between that. So I like to just kind of start off with that so you know where I'm coming from with this work. What do we mean by mental health co-occurrence? And so, again, I like to think about how I'm approaching this work. I use the phrase co-occurrence different than comorbidity. Comorbidity can sometimes, it can kind of hint sometimes that the initial diagnosis, autism, is impacting or leading to this other outcome, right? This other condition, versus co-occurrence saying we don't really fully understand the ontology of the co-occurring condition. We just know that it's there as well, right? So you can be autistic and be depressed, and they not necessarily be the cause of one another, right? But they are coexisting or kind of occurring in an individual, right? So co-occurrence refers to the presence of one or more mental disorders alongside autism. And we really didn't understand co-occurrence or even accept that it could exist up until the early to mid 2000s, right? In the mid 90s, autism was transitioned to autism spectrum disorder, right? And we changed our diagnostic criteria for autism and the classification for it. And at the same time, we see this growth in the neurodiversity movement that really calls for autism to be understood as an identity. And because of that, once we got there, we were able to say, well, if it's an identity, that means you can be autistic and have these other kind of co-occurring conditions kind of alongside it without it necessarily being an outcome of autism. And so that really allowed us to say, well, maybe someone can be depressed and autistic. Maybe someone can be autistic and have anxiety, autistic and have ADHD, and they not necessarily be the causes of one another. And so some of the causes for the co-occurrence oversights, though, are really the overlap of specific symptoms of mental health conditions and autism traits. So compulsive repetitive behaviors are common traits of autism, as well as common traits of ADD, ADHD, depression, sensory disorders, things like that, right? Anxiety, difficulties in emotion regulation, variation in non-traditional sleep and eating, or non-traditional sleep and eating habits, sensory sensitivities, and intentional social isolation all are traits of autism, but also traits of several other mental health challenges. And so sometimes those traits are overlooked as simply an outcome of autism versus being a outcome of other conditions that a person may be experiencing. And then for a long time, there was this fallacy that autistic individuals had emotional apathy, right? Essentially, they couldn't, if you're autistic, you couldn't experience these kind of in-depth, com- uh, uh, complex emotions. Once we kind of understood that's not true, once we got to a point that, well, autism is more of an identity as well, as much as it is a mental health condition, we said, well, these individuals are experiencing complex emotions. In fact, even those who have a harder time expressing them are still experiencing these emotions. And so if that's true, then it's likely they're experiencing some of these co-occurring conditions as well. And then communication differences can limit diagnostic tools. Most things we look at when it comes to depression, ADD, anxiety, are we measure that from scales that need verbal responses, right? We ask you what you're feeling. We ask you over the past 2 weeks, have you experienced this? And we need a verbal response or even a written response to help us understand that. And if there is a difference or difficulty with communication, that can limit our ability to adequately assess these conditions. And so just to kind of keep going with this co-occurring theme, right? Approximately 70% of autistic individuals are diagnosed with at least one co-occurring condition. And you can see here, really those mood disorders, right? Anxiety, depression tend to be some of the most kind of present. In the same time, conduct and so behavioral disorders tend to be the most present. And a lot of times the behavioral disorders are diagnosed before the autism, especially as we talk about Black autistic individuals, which we're going to get into in a second. But those behavioral disorders tend to show up before the autism diagnosis, but because they were there, they kind of hang around. And so, we found out 10 years later, this individual is autistic, but we also were saying they had conduct disorder throughout that entire time. So now they have conduct disorder and autism. And approximately 50% of diagnosed autistic individuals are diagnosed with multiple co-occurring mental health conditions. That means they're experiencing more than one of these co-occurring conditions, and we're just starting to get a grasp on what that experience is like for them. So autism and depression, this is really what my area of expertise is. Excuse me. That's my sign to myself to slow down, is to take a sip, because I'll start going really fast. Uh, but autism and depression, autistic individuals have an increased rate of depression. Approximately, based on the studies we have, about 20 to 28% of autistic youth report clinical levels of depression. That means they're meeting criteria to be diagnosed with major depressive disorder. Um, and the lifetime and current prevalence of depressive disorders in autistic individuals is around 14% and 12.3% respectively. Growing rate of suicide among autistic youth. So when I first got into autism research, was about maybe 5 years ago now. I have an older brother who's autistic, and so I've always kind of kept my nose in the literature and the research, but hadn't really formally done autism research. I was studying depression amongst Black youth. So I got into the autism kind of area field, and I wanted to know, like, what's happening with depression and autism. And I started doing Google searches, and I couldn't find hardly any literature on autism and depression. A little bit, but nothing strong. But I did find some stuff on suicide rates in autistic individuals, and I don't want to say pleasantly surprised, because not pleasant. I was sadly surprised to see the rates of suicide amongst autistic youth and the lack of research into suicidality, depression, anxiety, these things that we know are associated with suicide. Autistic youth are 10 times more likely to die by suicide. In fact, a recent article found that autism spectrum disorder was an independent risk factor for suicide in later life, meaning that being diagnosed with autism statistically made you increase your risk of committing suicide to be significant compared to other factors. Uh, and then signs of depression and suicide are often overlooked in autistic individuals, right? Deficits in social communication and emotional expression cause people to overlook kind of clear signs or maybe not so clear signs. And the difficulties in expressing depressive symptoms and mental needs from the young person, young autistic person, often creates these gaps in understanding and recognizing signs of suicide and signs of depression. And so autistic individuals are 4 times more likely to experience depression in their lifetime than their non-autistic peers. Impairments in social functioning are associated with various challenges, right? Fewer initiations with peers, fewer friendships, heightened loneliness. All these things are common kind of outcomes for autistic individuals. throughout their lives. And so all these things are also associated with increased rates of depression. Increased self-injury and regression of adaptive skills may be depressive symptoms unique to adolescents with autism. However, we still have not created a standing criteria to understand or measure depression in autistic individuals. So we're using kind of standard criteria for non-autistic individuals to try to understand what depression looks like in this population. If we know that there are disparities that exist, how can we comfortably say that the same scales that we're using to measure depression and non-autistic youth will adequately measure depression in autistic youth? And so we just really haven't, we're just getting to a point where we're starting to say, well, maybe we need to think about what scales exist, what can be adapted. We're seeing this a little bit more, but we haven't gotten to a point where there's a common scale for depression. And maybe there's never going to be just one, right? But we're starting to have that conversation, but it hasn't moved as much. So there are false assumptions that autistic youth don't have complex emotions. We talked about that, right? But also stigma associated with autism often leads to masking and camouflaging behaviors as a social strategy. And so if someone is experiencing masking or camouflaging, right, where they're trying to hide their kind of traditional autistic traits, then you can also see in doing that where some aspects of depression also being cloaked and being hidden. Right? And then typical signs of depression and suicide ideation overlap with characteristics of autism, right? Social isolation, rapid mood changes, irritability, irregular sleep patterns, changes in appetite, changes in social relationships. All these things are common traits of autism as well as common traits of depression. My work, though, specifically looks at racial identity, primarily focusing specifically on Black people. My research asks, what does it mean to be Black and autistic? And how does that impact someone's experiences with depression and other mental health conditions? So I come from a intersectional approach. I use an intersectional approach in my work. Right? Intersectionality being multiple forms of inequality associated with identities that interrelate in different contexts over time. Right? It allows the person doing this work to give greater consideration to the interconnectedness of identities and view people in their whole context, right? As we get into race, gender, socioeconomic class, nationality, physical ability, mental abilities, all these different things that play into how someone experiences life. And again, going back to what I stated earlier, I treat autism often as a social identity as much as I do as a medical condition or mental health condition. And because of that, that means I have to think about how do these identities overlap and impact someone's experiences socially. So if we think about just being Black and being depressed or experiencing depression, depression or depressive symptoms are associated with increased risk of suicide, suicidation, and self-harm, right? This is, I think, 2017. 2017, suicide was the third leading cause of death for Black non-Hispanic individuals in America, Americans, excuse me. And the fourth leading cause for those between ages 20 to 44 years old. So these are some of our most, I hate the word at risk, uniquely vulnerable, I'll say, individuals at a young age going through significant life changes. And we see these high rates of suicide existing for these individuals who are Black. Black youth suicide increased 104% over the past 20 years. Similar increases in physical injuries from suicide attempts have been seen. So whether or not someone actually completes suicide, actually causing physical injury from the attempt has increased by, I think it was 122% over the past 25 years. In 2015, almost 1,700 Black children between 5 and 17 years old committed suicide, 75% of them being Black boys. And we look at autism, the ratio of autism for boys to girls is about 4 to 1. All right. And so, again, a population that's uniquely vulnerable, having this abnormally high rate of suicide that we're really not talking about. In 2018, suicide became the fourth leading cause of death among Black youth between age 15 and 24 years old. That's our transition age, right? That's that age I'm learning how to become more independent. I'm taking more control of my life. I'm making more independent decisions. And for autistic youth, we know, right, in research, the transition age for autistic youth tends to be a significant challenge because I'm not only becoming independent as an individual, my healthcare, my needs, my independent living is all becoming part of part of my responsibilities. And so there tends to be a very difficult time for autistic youth who are transitioning out of high school into college, into the workforce, their healthcare needs are kind of transitioning. What services they get as a youth is transitioning to whether or not they actually still get those services as adults, if they exist for adults, etc. And so during that transition phase, we're seeing for Black youth an abnormally high, extremely high rate of suicide. We tie all that together. Sorry, some of my formatting is off here. This is supposed to be blended, so sorry that it's hard to read. Like my formatting changed here. Um, Black autistic youth are diagnosed on average more than 3 years after their parents express concerns, and on average about 4 years later than white autistic youth. That means the services that they would receive at a younger age is coming at a later age. The help, the support, even just the recognition of what they're experiencing is not being identified until later in life. Nearly 25% of Black autistic individuals have significant issues with conversation, language, and social skills, compared to about 11% of white autistic individuals. And on average, Black autistic individuals access mental health services later than their white counterparts. And 20 to 28% of autistic youth between ages 11 and 17 experience depression. But if we look at what we said about Black youth and depression, and then combine that with being autistic, we have to consider that possibly there's some unique vulnerabilities there, right? Being Black and being autistic in a society that is both that both navigates racism and ableism. And so, similar to intersectionality, I also approach my work with discrete theory. And I know I'm flying through some of these kind of topics pretty quick. I just I don't want to sit on anything too much, but I'm happy to answer more questions about any of the theories, any of the work, research at the end of this as well. But discrete theory is really how macro level issues like racism and ableism, among other discriminatory processes, impact a Black disabled individual's day-to-day living. All right. To be Black and autistic, and how do I navigate ableism and racism in a society that perpetuates both? And so it really calls on using intersectionality, but also understanding that it's a very unique intersection. And we have to approach it in understanding people's unique experiences. We can't treat one and treat the other. We have to understand how it overlaps with one another. And so I approach most of my work with discrete theory as well. Recently, an article came out that talked about the dual masking phenomenon. And I talk about this a little bit in a previous article I wrote a few years back, where we talk about the combination of being Black in a racist society and autistic in an ableist society, and how that creates this unique intersection. But what does that really mean? Well, research shows that autistic individuals often take part in masking or what we call camouflaging behaviors, right? Trying to hide aspects of my autistic identity so that I can blend in, emerge in with non-autistic populations, right? For safety reasons, right? I'm trying to caution myself and protect myself from mistreatment. I'm trying to, fit in. I'm trying to protect myself cognitively. I don't, the overload of trying to navigate both of these identities is difficult. We know that Black individuals often take part in code switching, right? If I'm in a predominantly white community, or a community that's not a Black community, often taking part in behaviors that will protect me by hiding aspects of my racial identity. I may not be able to hide that I'm Black, but I can change the way I talk. I can change the way I do my hair. I can change the way I move. I can change all these different things that are kind of stereotypical ideas of Blackness, as a way of fitting in and safe and protecting myself in this space. So I always highlight that masking and camouflaging and code switching are not necessarily tools because I just want to fit in, but they're tools of protection in this space. As a Black person, if I'm in a predominantly white space, I'm cautious about how I'm being perceived, because how I'm being perceived can put me in a dangerous situation. And so I have to be very cautious about my approach. I always say, as a Black man, when I'm in certain spaces, I think about what my tone sounds like, what my movements sound like. Do I seem threatening? Not because I'm concerned about someone else's well-being, but because my own well-being is based on how others perceive me as a Black man. So I'm going to share with you some data and things I got from some recent studies. I'm not going to spend too much time on the science of it versus talking about the outcomes of it. For those who are interested more in the science and kind of the analysis that we ran, I'm happy to talk about that more in the Q&A or just a different time. But just for sake of time and interest, I just don't want to dwell on the statistical kind of analysis versus what we know, what is leading me to do in the intervention kind of space that I'm in. So the three studies are, one is actually published. It's the initial evidence of depressive symptom disparities among Black and white transition autistic youth. One is doing within group analysis, looking at demographic differences for Black autistic transition age youth with and without a history of depression. And then the last one is a qualitative study that looks at how do Black autistic youth understand and experience depression. So the first study, data comes from a randomized control trial. A colleague of mine, my mentor, Dr. Matthew Smith, led this original study, and then I did this kind of sub-study, subsample off of that data. And so we used the pretest data to look at depressive symptomology for the Black participants in this study. Those who were included were between age 16 and 26 years old. So again, that transition age, had at least a third grade reading level, were willing to be video recorded because this is part of a larger randomized control trial. And we can see kind of on average, the Black autistic individuals were a little bit older on average than white autistic individuals. But other than that, every other kind of demographic characteristic was pretty similar. So nothing else was significant. Everything else was similar as far as the difference. So it was a pretty similar population other than the age. And again, I'm skipping past a lot of the science and just going straight to the results. What we found in this was that while Black participants' rate of clinical depression was a little bit higher than white participants, but it wasn't significant, their rates of depressive symptoms were significantly higher than their white autistic peers, meaning that the Black participants in the study reported having symptoms of depression at a significantly higher rate than their white counterparts. Now, this is a small sample. I think we had a sample of about 40, what do we have? About 45 participants in the study. So it's a small sample. Unfortunately, the data just, we're still trying to find the data that allows us to do these things on a larger scale to see if we're seeing population-based kind of differences, right? So while clinically depressed at the clinical level, we do see a difference. It's just not significant. We're seeing as at the symptom level, it was significant. So this is showing us that there's something here. Maybe there's something we need to look at more, especially given this population, other than the age difference, was pretty overlapped, with some pretty similar demographic characteristics. The next study that I did just kind of offered this, thinking about, well, what does this look like, is I wanted to look at within group. I studied Black people. I studied Black autistic people. That's my interest area. And it's important to understand differences just within the group, to not see a group as homogenous, but understand the heterogeneity that exists in that group, right? So this study looked at how do Black autistic transition age youth with a history of depression, which we use as HX depression, differ in demographics, mental health diagnosis, and service utilization compared to those without a history of depression. So essentially, what are the demographic differences between those with a history of depression and those without? And so again, the within group comparison is important because I was able to focus specifically on Black individuals. It challenges the false narrative that minoritized groups are homogenous. It avoids perpetuating deficit perspectives. So I'm not looking at whether or not they are less than or equal to or different than white people, but understanding them within themselves. And it centers Blackness in the unique experiences of Black autistic individuals. And so this study used data from my colleagues, Sean Eek and Carla Mazewski at the University of Pittsburgh in their study called REALS, the Relationship, Employment, Autonomy, and Life Satisfaction Study. It's a study that's looking to develop new self-report questionnaires for various aspects of life. We looked at those between 18 and 25 years old, so still around that transition age. This data came from Spark. Thank you, Spark, for this study, for this data. And we looked at the Black participants. We had about 94 individuals in this study, all with formal diagnosis of autism. And we had scales that looked at depression, anxiety, and then self-report history of depression. And so lifetime history was interesting. 68% of the participants in the study reported having a diagnosis of depression at some point in their life. Those who did have a history of depression were older, significantly older, were more likely to report being female or gender diverse, reported higher levels of education, and currently were working part or full time compared to those who were not working, right? And so significantly, statistically, we see more likely to be women or gender diverse, more likely to have a job, more likely to have a higher education, be older, right? And so we were kind of trying to figure out, what does that mean? You know, you would think that those who have a job, those who have higher income would be happier, but we started kind of getting into this space of, maybe the stress of maintaining a job and having a high powered job could lead to some of this depression, or could it be access, right? If I have a job and I'm higher income, I have greater access to clinicians, to therapy, to support. Maybe the diagnosis is I'm just getting diagnosed because I can get diagnosis versus those who have less access to it. It can also be function level, something we just didn't have in the study, but it could be function level as well playing into this. When we looked at mental health service use, um, we saw that, oh, there we go. Those with a history of depression were more likely to have a history of individual therapy use, but there was no significant differences in current use of any mental health services, no differences in psychiatric hospitalization, and nearly half of all the participants in total have been hospitalized at least once in their lifetime. And so, other than individual therapy use, we're still not seeing any differences as far as treatment for depression for this population. And what was most interesting in this study was that even across all these rates, right, those with history of depression were more likely to have a history of anxiety, OCD, post-traumatic stress disorder, ADHD. Again, I think some of this is showing up as access to services to identify these things. But we didn't see any differences in current symptoms. So those who have been diagnosed with depression compared to those who had not been diagnosed still had similar symptomology, which is speaking to, again, being Black and having access to services. Um, there's this kind of underdiagnosing that we seem to see in our non-autistic population of Black people that we're seeing similarly here in this population, where those who, where we're seeing Black autistic individuals not being diagnosed, but still meeting the criteria when we look at symptoms. And so this gets into an interesting area around what can we be doing to improve both understanding their symptoms and helping them communicate their symptoms more clearly so that we can get those formal diagnoses and get that formal treatment that they may need. And then the last study I'm going to talk about came from informative interviews that I conducted around when I was in the beginning of developing a mental health intervention for Black autistic youth. And we want to know, how do Black autistic youth understand and experience depression? And so we did a demographic survey, looked at depression scores, help-seeking behaviors, and then we did interviews over Zoom. This was 2021. We collected this data, so COVID was still kind of running things, and so we did these interviews over Zoom. And to be part of the study, they identify as Black, African American, have a formal diagnosis of autism, between ages 16 and 24 years old, and read, speak English. And we also interview parents and caregivers of these autistic individuals as well. And these were about 60-minute one-time interviews, in-depth, semi-structured, and we had about 15 participants, 8 youth and 7 parents who participated in the study. And briefly, checking time, we're good on time. Briefly, what we found, first off, depression was a common experience. Every participant, we did not look at participants who only had depression. You just had to have that earlier criteria. Oops, excuse me, I'm too far. Where identify as Black, African American, have formal diagnosis, be between this age, speak English. We did not specify that you had to be depressed, but all of our participants reported depression. All of them met criteria for depression using the PHQ-9. So depression was a common experience. Most of it was self-identified. Most participants stated that they figured out that they were depressed on their own. If they didn't figure it out on their own, usually a school staff member identified it. So many of them said, my teacher thought something was off. I go to my special education teacher. I have a advocate in the school. They noticed something was off with my behavior. They called my parents and told them, or they came and talked to me. We found that burdenism was one of the biggest things. And these are some of the quotes from participants in the study. But burdenism came in the form of from both parents and youth who were saying, I think I'm depressed. I think I'm even suicidal, or I know I'm depressed and I'm suicidal, but I'm afraid to really tell my parents or tell anyone else because I don't want to be a burden on them. They already deal with situations. We had participants say, my parents already deal with my ABA. They already deal with my IEP. They're already dealing with my medication. I don't want to burden them with anything else. From the parent side, we saw a lot of, I think my child is depressed. Matter of fact, I'm pretty sure they're depressed, but I don't even know how to approach them. I don't want to worry them if they're not. I don't want to bring up a topic if they're not depressed and put more stress on them. And so there's also the perceived stigma, right? The concern that, well, my child's already navigating difficulties with autism. If I say they're depressed and suicidal, what is that going to look like for them as well? What kind of things go on their record? What is that? How does that impact the services they may or may not get? How does it impact how people are going to treat them? Symptoms of depression, sadness, and changes in behaviors are the most identified things, right? I'm experiencing extreme sadness, isolation as well. That should be in there, but it's missing. Isolation was also cause of depression, loneliness, right? But feeling sad, feeling these ongoing pervasive sad feelings, and then changes in sleeping, eating habits were the kind of most common symptoms. And then causes, a lot of participants said, they felt lonely. Some experienced racism and discrimination, and that triggered them. Racism and discrimination was interesting because there also was a vicarious experience, right? This is 2021. We collected this data. This is George Floyd is happening, right? A lot of the participants were like, I see it on the news. I hear people talking about it. I don't fully understand it. People are talking to me about race and racism, but I see it. And so my concern is that this may happen to me. I'm concerned about how to navigate this. And I did not include the quote in here, but there was one participant who said, if this happens to me, I won't know how to talk my way out of it. Talking about if he was stopped by the police like George Floyd was, because he struggled with communicating and talking about his feelings. So in totality, what does all this mean? We need more culturally grounded diagnostic tools for depression among autistic individuals, first off. We need more tools in general, but specifically when we get into these populations that have unique cultural differences, right? Improved recognition of depressive symptoms for Black autistic individuals is needed. Being depressed and Black is different than being depressed and white. I can't isolate myself by living in a home with multiple people. I can't necessarily ignore authority, the danger that it exists for me as a Black person. So the same things that we may say, well, this is a common trait of depression for this young person who's white, is going to be different than those who are Black. And if we add in things like autism and the kind of communication differences that exist here, we have to be able to understand the differences and how depression will show up, which means we need greater exploration of depressive symptoms and diagnosis amongst Black autistic individuals. We need to explore this even more in depth, understand how are they experiencing depression, what they think it is, how are they understanding help seeking, how are they seeking out help. Many of these youth are saying, I'm asking for help, but I don't really know how to ask for help quite in a way that's effective. I can say that I'm sad, but I don't really know how to explain everything else. And then we need improved and innovative strategies to address mental health needs for Black autistic individuals. Right? Unique ways that utilize the new way we're in. We're in a technology time, or a time when AI is blowing up. We can use these things that exist to improve both our criteria, our diagnosis, but also how we train people to support autistic individuals, as well as how we train autistic individuals to support themselves and address things they need for themselves. So that brings me to the last little bit we have, thinking about interventions, right? There are a few evidence-based interventions and programs to address the mental needs of autistic individuals, right? And interventions tend to fall in these kind of four areas: behavioral interventions, pharmacological treatments, therapeutic interventions, and then skill-based interventions. When we talk about autism, these are kind of the areas that we see most mental health interventions kind of fall into. My work has really gotten to this kind of communication and skill-based, kind of component. And so with all the data that we collected from the 3 studies I spoke about, my research team and I have started to develop a tool called Asking for Help. It's a simulation-based mental health application, looking at expanding depression literacy, help seeking intentions and behaviors, communication skills, self-efficacy, addressing stigma, and ultimately lowering depression. And I only put a few pictures in here because we're in development phase, and I'm always cautious about showing things before they're before they look pretty enough to present to the world. But this tool uses simulation technology, to support having ongoing conversation about depression amongst Black individuals. And it brings in the community engaged research and the discrete theory intersectionality that we talked about. And so we did this community informed, have a fully engaged community advisory board that helps support this tool, give feedback on it, give thoughts on it, and see every changes that we make throughout. It's developed to be sustained in the community. It really expands its mental health literacy, primarily on depression. So expanding knowledge of symptoms, knowledge of causes, knowledge of treatments, and understanding of the condition itself. And then it uses the theory of help-seeking behavior, right? Considers sociocultural context, race and disability, that discrete component, right, on help-seeking process. What does it mean to be Black and ask for help for a mental health condition that is heavily stigmatized in the Black community? How do my beliefs about depression, my understanding, impact my experiences? And how much agency do I have to address these things on my own and to seek help on my own, especially for transition age autistic youth? This is just a kind of a quick, I'm working with a company called Submersion to develop this program. We use what's called people-sim technology, which is really unique because it allows for these very in-depth conversations with this simulated character. And I'm happy to talk more in depth about this during the Q&A as well. But that conversation is unique every time. So when I log into this program, I use this tool, I'm not having the same repeated conversation trying to fix it. I'm having a unique conversation with this character ongoing, gives me a chance to practice different ways of talking about depression, depressive symptoms, and things of that nature. And so again, I'm cautious about sharing things in their rough form because it's in rough form and we're in the middle of doing a feasibility evaluation of the tool right now. But roughly the participant gets to pick from two levels, right? An easier kind of going character and then a more difficult character. And they get a chance to practice not only talking about depression and asking for help, but also self-advocacy, speaking up for yourself, keeping a conversation going when someone seems disengaged. How do I convince someone what I'm experiencing when they're doubtful or trying to help to the point that they're ignoring me, right? The savior complex, they want to help me so much that they're not really listening to me. And so participants they do a literacy component first, learning about depression, what depression is, and specifically, what does depression look like for Black autistic individuals? And that's based on the information we got from those interviews and things like that. What does it look like to be Black, autistic, and experience depression? What are some of the causes, some of the symptoms? What's unique about it? After they do that, they can choose their level, pick a symptom of depression that is common amongst Black autistic individuals, again, based on these informative interviews that we did and the data that exist, and then have an ongoing conversation with a simulated character. In this case, Miss Daniels is a special education teacher who will, be there to ask you about what you're going through, what you need. And your job as a participant in the study, or a user of this program, is to do your best to explain to others, to the teacher, what you need, what you're experiencing, the symptoms that you're going through. At the end, you get a score out of 30, where all of this stuff right now is being reassessed because we're doing adaptations to the program based on user feedback. But you get a feedback about how well you did, what things you can impact, things you can improve and change to improve your conversation skills, to advocate for yourself. You have a character down here in the corner that gives you live feedback as you're having the conversation. If you're struggling, they may give you some advice on what you can do better. If you're doing really well, they remind you you're doing really well and congratulate you on doing really well. And the idea is that it creates this desire to repeat again and to do this again. So asking for help, or A4H as we call it right now, is currently in development. We're working with Black autistic populations to do this work and develop this program and make it as innovative and as unique to this population as possible. And that is kind of where this work has really led. Autism and depression for Black individuals is unfortunately understudied. It's kind of my job now to make sure we are studying it, making sure we are digging into it. But improving literacy, depression literacy, improving access to services, improving the diagnostic tools to identify these things, but also improving conversation skills for autistic individuals, as well as for the caregivers, right? So the other side of this tool will be, how do we help parents have these conversations, and how do we help clinicians and specialists better have conversations about depression with Black autistic individuals? Oh, I didn't mean to do that.
Hey.
Sorry, this is a sample of the tool. So let me see how much time we have left. I'm not going to play the sample for time's sake, but the tool exists here. Some references. There we go. And that is all I have for today. I'm happy to answer any questions or talk more in depth about anything that I know I skimmed over quite a bit. But thank you all for your time and for listening. I look forward to your questions.
Thank you so much, Dr. Williams, for your presentation. I know that we all enjoyed it. I deeply enjoyed it. We have some time left for questions, so let's jump right into them. Okay. Okay, so let's go with the first one. Where should people look for opportunities to collaborate, participate, and educate as a parent and advocate?
Oh, that's a great question. Well, I do have the link to my, my study here. So you always reach out. I'm happy
It
to have
works.
conversation with parents anytime, both as a researcher, as a clinician, and as a sibling of an autistic individual. That's so personally on that level. Um, I think it's really, we have to think about the circle that kind of encompasses our children, teachers, friends, colleagues, whoever is kind of in their network, and really communicate with them about what they're seeing, right? So one of the biggest things we saw when we talked to parents about when they noticed their child was depressed, it was changes in behavior. They were sleeping more. They weren't eating like they used to. They were a little more aggressive than usual.
Mm,
Sometimes we can write that off as changes in medication, changes in treatment, changes in therapy, part of their autism. But if we're noticing that it's happening consistently, then it is worth saying, well, maybe there's something more going on, and helping and working with our children to help them communicate what they're feeling better, but also thinking about how we understand their behaviors. Um, Unfortunately, when it comes to mental health, like depression, we're just still in this kind of infancy phase of understanding how it's showing up in
hmm
the population. So I really wish I could tell you that these tools and diagnostic things exist, but we're really in that state of like, how do we create these diagnostic tools that adequately measure them? But and being our child's advocate, speaking up to their clinicians, their ABAs, their special education teachers, saying, "Hey, I'm noticing something's going on here. Can we try to do some kind of assessment for depression or anxiety or suicide ideation?" I hope that answered the question.
Yeah, great. That was great. Sort of along the same lines, are there cultural nuances that make depression show up differently across ethnic groups and genders?
Absolutely. So what it means to be Black in society, first off, means you're navigating things like racism and discrimination. You're navigating things like, well, more likely to experience low income existence, more likely to experience community violence, more likely to experience police brutality, all these things that we know exist, right? Turn on the news,
Hmm
we see a lot of these things, right? That means the things that can lead to mental distress and ultimately depression are different than those of other racial identities. At the same time, stigma and communication and how we communicate about mental health in certain communities is going to differ, not just for Black people, but those of other racial and ethnic groups as well, right? How we talk about depression, whether or not we function through it, right? Research has shown that Black people tend to function through depression. I've I've been depressed for 20 years. My mom was depressed, but you don't get to stop.
hmm
You don't get to suddenly take a break, you know. And so those things show up in how we raise our children, what we put, kind of instill in them, and how we recognize changes in behaviors. Also, the lived experience, right? If you are from a community that often has multiple generations living in one household, how can I isolate myself when I have 10 people living in my home? So maybe isolation isn't a symptom that we will recognize, right?
Okay.
For boys, we may see more aggression than for girls, right? Being more physically aggressive, being more outgoing, right? Or suddenly he's talking a lot and he's really hyper and really, that's not traditionally how he is. Those things are often impacted by gender norms, expectation, things like that as well.
Great. What can professionals working with these children do to better support them and decrease the likelihood of dying by suicide or identifying depression or being
Great
depressed?
question. So I go back to kind of really connecting with the network. As a clinician, it's very easy to stay in my office, meet with the client, go through the checklist and okay, next. But really thinking about their larger network and how do we can I communicate with that network? Can I get a sense of if there's been changes across the board, not just in my office, but are we seeing changes in the school? Are we seeing changes with their friends? Things like that. Identifying those things will help us get a better sense of what's happening here. Um, so that's one thing for specialists. I think it's also adapting our understanding in our language. We can't approach working with autistic individuals the same way we do with non-autistic individuals. We can't assume that the symptoms are going to show up the same. And so asking kind of more directly, are you feeling some of these symptoms, but also helping them understand how to express those symptoms. So part of the asking for help tool is trying to improve that literacy, but also that communication about depression so that we can help them better communicate their needs to us. And then the other part of that tool eventually, as we, when funding kicks in and NIH figures out what it's going to do with funding, like things like that, is can we building a tool that helps clinicians and specialists understand how to communicate with this population better as well and adapt our own kind of clinical thinking to a population that may have more difficulties in communicating their needs.
Does the average age of diagnosis by race and the subsequent social intervention therapies, in your opinion, play a significant role in depressive symptoms developing at higher prevalence?
I would imagine so. So my opinion, again, research wise, I couldn't tell you for sure. We just don't have the data yet, or that we haven't ran the analysis yet. But opinion wise, and I'll say kind of my educated opinion, yes. Being diagnosed at a later age with autism, first off, means you're getting access to services at a later stage in your life, especially during key developmental stages. We see poor communication amongst Black autistic individuals, a lot of times associated with getting access to services at a later age. Um, but also, we see because of the later diagnosis, sometimes we see Black autistic individuals being diagnosed with conduct disorder, mood disorder, suspended and expelled from school several times before they get a formal diagnosis, right? Arrested, detained, harmed before they get a formal diagnosis of autism. And so they're going through all this harsh treatment. They've been labeled incorrigible. They've been kicked out of school. They've been isolated from their community, from their friends in these times. And so all those things are going to impact if and how I experience depression. All those things are symptoms, or excuse me, are correlates of depressive symptoms and depression diagnosis. And so if we know that these things exist differently for Black youth, especially based on the age and the time in which they're diagnosed, then I would expect that also is going to impact the rate in which they're diagnosed, how old they are when they're diagnosed, and what treatments they're able to get or are accessing by the time they get the diagnosis.
Okay. Why are behavior disorder diagnoses happening before the autism diagnosis? Can you share a little bit on that if you have an idea?
Yeah. So I kind of alluded to that a little bit in a previous answer, right? Research, data shows, and personal experience shows Black youth are perceived to be more problematic, have greater behavioral issues, or more likely to be suspended and expelled from schools, even when they're exhibiting the same behaviors as their white counterparts. Blackness is perceived in our society as in a negative light, unfortunately. So Black youth exhibiting problematic behaviors often are perceived to be just a bad child, right? This child is kind of out of control. He does not know how to control himself, does not regulate his behavior. And those things are often explained by behavioral disorders, right? Conduct disorder, opposition defiant disorder is tied to the stereotypical view of Blackness, especially for Black boys, right? So that part exists, right? They're living in a society that sees being Black as a problem. The other part is access to resources. In our society, unfortunately, Blackness is often associated with lower income. Does my school have reliable therapies or excuse me, assessments? Do I have clinicians in my community? Am I on a wait list for 3 years to get my child assessed and diagnosed? In the process of getting that assessment, my child's still in school and they're still being seen as a problem. Do I have reliable health care? Things like that. All these things play into, and all these things are associated with race in our society, unfortunately. And so we tend to see those labels kind of thrown in. And then for schools, a lot of times the label is how you get the services. I get an IEP if I give the child a label. Well, we don't have someone in here who can assess autism, but if we label this child ODD, OCD, ODD or conduct disorder, we can still give them IEP. They can still get treatment and services in the school setting at least. Sometimes just giving the label allows them to get services, but that label has consequences long term.
Right. We have time for a couple more questions, but these are great questions. Keep on sending them in. My next question is, what other specific techniques are you aware of to help guide an individual who may have limited communication skills to engage in therapy?
Yeah, I mean, there's so many things that are kind of in trial stage right now. There's a lot of these kind of communication tools that help people communicate in different ways. I know ABA therapy has kind of gone through some changes over the past 5 or 10 years that are, a little more sustainable and probably less problematic. So there's a lot of different therapies that exist. How effective they are, I think it's going to take time to really measure. And because we're 20 years into understanding that these co-occurring things actually exist, research unfortunately is slow. But I do know that people are thinking about, especially for Black youth, because there's also a higher rate of nonverbal Black youth or autistic than those of other racial groups. trying to pick up things like body language. How do we really adapt body language to understand symptomology? Can we measure different aspects of the body to pick up anxieties and depression and things like that? So there's some of these more biological kind of tools as well that are showing up, picking up on cortisol levels, things like that that are existing. Uh, Again, all of it's in this infancy stage. So I'm really appreciative of being to share this work. So hopefully we really uh, create some hype around how can we dig into this more, but also for Black parents, um, communicating these needs, advocating for our children, bringing this up to their doctors, their psychiatrists, their ABAs, their pediatricians, right? These changes in behaviors. I think that will also lead to some unique ways of assessing as we kind of make it known these things exist.
Okay. For our researchers listening in, how can they successfully design studies for Black autistic youth and their families? And how can families find and participate in research that represents them? They can scan that QR code.
Yes, that'll be my
Families.
response. Just scan the QR code. Also, organizations like Spark that are doing amazing work. I'm using Spark as one of my recruitment tools. They have the research match participant pool, which is really dope. Community engaged research is my approach. Community engaged research, community based participatory research. It's slow, unfortunately. Like if you do community engaged research, you go at the pace of the community. If you're someone like me who's junior faculty, you're chasing tenure, you're also like, well, I got to publish, I got to do this, do that. But at the end of the day, the important aspect of my work is making sure we're creating unique and useful tools, and that I'm actually serving this community, right? I'm serving my community. So it is really engaging with the community. There are hundreds of individual organizations and programs that focus on Black autistic youth, spread out all over the country. Some are very siloed, some are very quiet. A lot of them are started by parents and advocates. Now, I found out my child was autistic. There was no support and services from me, so I created my own program of support. Um, I'll give a shout out to the Color of Autism in Detroit, the Black Autism Coalition out here in Boston. I'm looking at my whiteboard behind me because I got a list of like organizations that I've been like partnering with. Mass Rehabilitation, I think they changed their name recently. Massachusetts Department for Special Needs Children. All these organizations do a little bit of something. Mm-hmm. Part of what I've been trying to do is like connect them and say, hey, let's all come together and really bring in these resources and things like that. And as a researcher, how can I also bring in some of the skills that I have and helping understand what's happening in this community, but really building that rapport, making sure we bring Black autistic individuals into this work, not just studying them, but they should be leading some of the charge, or at least having say in it, right? So I have my community advisory board that has both parents, Black autistic self-advocates, autism specialists, all part of it, that have say in what I do. They see the work before I put it out there. They see the research. They see the interventions, kind of the phases in this, and give me kind of feedback on where we're going with it. They see the data before I actually make any changes to the program based on the data, and help me interpret that. It's important for researchers to really slow down and really navigate the community. And community engaged research means, what does the community need and want? So when I developed A4H, I did not come up with the idea by myself. I had ideas, my mentor had ideas, and then I met with some community members, did informative interviews, and I was like, hey, we have this technology. What would you like seeing done with it if we could do anything with it? And they gave me the idea for a mental health literacy and help seeking program. So they said what they wanted, and I said, well, let me see what I can do based on the resources I have and the skills I've had, and that's how we led to this. So I wish I could say like fight the system and say, let this research take its time and pace it needs to, and not have to worry about tenure. But it is really slowing down, letting the community really guide the work.